אתה לא מדבר כשאתה יושב?
כן.
One of the places I started to do these sort of talks in was in Uganda, in East Africa. And the problem there was we didn't have PowerPoint then. We used to have those overhead projectors. And the power was always going. So what I did learn there was always to make sure I had some chalk so I could write on blackboard. So it was the same here, but for high technology.
Paper and pencil.
Paper and pencils, always good. Always good to fall back on. Right, well, thank you. It's wonderful to meet you all. I'm very pleased to be here, actually. It's always, for people like me, it's always a big learning to go to another country who have similar but different experiences, and to sort of it puts us everybody into perspective then. So it's always nice to be able to do these sort of talks. If I can just explain, I am a psychiatrist. I do clinical work as well as some academic work, and my clinical work is now solely with people with long-term mental health problems, specifically with psychoses. So nearly all the people I see have either schizophrenia or bipolar disorders. And I work in an area of southeast London, where the Maudsley Hospital is. Maudsley Hospital sort of was one of the first general hospitals after the asylums were built in the 20th century. It was the first one to have outpatients, which is important. And I work in a community team. And of course, as you can imagine, London is a very cosmopolitan area. And I work in a part of London that has the highest percentage of Africans. So about 60% Africans, or people from who originated in the Caribbean. So about 50 to 60% of the patients we see in our team will be black Africans or Caribbeans. So it's that sort of area that we work in. And it's a relatively poor area, traditionally. So what I wanted to do today, though, was I was given it, it's not my title, and it's always challenging when you're given something like that. What can we learn from England? Well, I think if you go on to the next slide, I think I can probably give you a clue about it. I can only tell you two real things ultimately. One, if you want to improve the lot of people with mental health problems, it does take time. It isn't done overnight, and there's always, you move forward and you move back a bit, and I think the history in England is like that. But also, I think it requires quite a change of mindset. We've got to change our attitude, the way we think about disability as a whole, and people with mental health problems, and their role and function, and how they can, how they live in society. But also, it needs cooperation, and by that I mean at every level. It needs cooperation at the ground level between, people, professionals, and people who use mental health services. It requires cooperation between organisations that provide services for people with mental health problems. And at the government level, it needs policies that are thought of across several government departments. So that's the sort of lesson. Just to be clear about what I mean by social exclusion. Those are sort of taken from the literature. And if I can read the first one, and this was written by a government department which no longer exists, but it was called the Social Exclusion Unit, set up in 1997, and they said it was a shorthand term for what can happen when people or areas of the country suffer from a combination of linked problems such as unemployment, poor skills, low incomes, poor housing, high crime environments, bad health and migration. So it emphasises that things like poverty, low income, is a big aspect of social exclusion. But you've got to link it with all the other problems that it is actually associated with. And I think that second one tells you something important too, that those, it says, most important characteristic of social exclusion is that these problems are linked and mutually reinforcing and can combine to create a complex and fast vicious circle. So what you're doing often with people's social exclusion is it's not just a simple matter of people being excluded or not, but often there are factors operating that make it worse and some factors that can improve people's inclusion. But ultimately, this is the definition I use and the way I think, and that's from the London School of Economics. They have a Centre for the Analysis of Social Exclusion, which has historically had some enormously important academics in it. And they just define it very simply. An individual is socially excluded if he or she does not participate in key activities of the society in which he or she lives. So it's about the way people can participate or not, which I think is the key thing. And remember, that's not a matter of choice for those people. If they're excluded, they can't participate because of many social and institutional factors that are operating, stopping them doing that. And that can apply to anybody in society. We know it applies to people with disabilities and mental health problems. It's a serious problem for them. Next one. Okay, that was just, I'm just showing off my book now. That was a book we put together. I didn't write the whole of it, but I led a group at the Royal College of Psychiatrists, and out of the group we wrote, we put together a book on social inclusion. Could have read social exclusion, but we wanted to be a little more positive than that. Social inclusion and mental health. And I'll remind you what social exclusion can be about, at least at the material level and social level. It means that you don't participate because you haven't got enough money, in a sense. You can't purchase things, you're poor. It also, you're excluded because you're not productive in some way. That really is to do with employment, education, are the two key things there. It's because you're excluded from social interaction, so you're isolated, your networks are apart from others. It also means you're politically, in a sense, disengaged. I mean that more as much in a civic sense. You're not included in your community, in decisions, in having a choice in those areas. And finally, I think this is important for people with mental health problems, that you can often be excluded because you have poor health. And I just don't mean poor mental health, but poor physical health. And you're often excluded from the services. You don't take them on as other people might. And those are the key areas, I think, of social exclusion. So what's been our experience in the UK? Well, remember, we've had a long history of treating people with mental health problems. The first psychiatric hospital in England, in the UK, was opened in the 12th century, and it was opened by a group of nuns, and it was called the Hospital of St. Mary of Bethlehem. Now, you'll probably not know this, but the term Bethlehem, of course that's very near to you here, has been corrupted to take over what they called Bethlehem, a hospital called Bethlehem, or Bedlam. And you'll probably recognise the term Bedlam. It's used as a sort of word to sort of express madness. But Bethlehem Hospital did exist. Bedlam did exist in London. In fact, the sister hospital to the Maudsley Hospital where I work is called Bethlehem Royal Hospital, and that is a sort of, if you like, a modern day St Mary of Bethlehem Hospital. It moved around London and now is located roughly where I work. Now, we had loads of asylums. They were built up in the 19th century, and we closed them, and we developed community services, and I think we want to cover that. The other thing that's been important in our experience has been the development of quite a strong welfare state. In fact, I don't think we'd have been in the position now we are in British psychiatry in British mental health services if we didn't have such a strong welfare state. It allowed us, I think, to close those asylums and develop community services. We've also had, and I think this has been important, a focus on people with severe mental illness, because we didn't want to make the same mistakes as they did in the United States, and also a focus on primary care. In the UK, that is general practice, family practice. And both that aspects of specialist services, primary care services, I think have been very important for people in mental health problems. And we've also, I think, more latterly, highlighted this idea of social inclusion and recovery in policy. And I think that's been a big shift for us. Next slide. So there we go. What we did, we went from asylums, that's one example, I worked there once in my career, to community. That's a community mental health centre. I also worked there at one time as well. So that's the shift that we've made. And that shift only really happened at the end of the 20th century. So it's relatively new. Next slide. We also remember, if we're...
Excuse me, in the community services, do you have also some kind of clinical treatment, like hospital, or
Well, no.
only daycare?
No. What we have a system, a health system, which has a hospital treatment, but that's inpatients, and other facilities based in the community. Whether that's a community mental health centre, an outpatient clinic, a day hospital, etc.
But to deal with acute cases, they go to general hospitals, or do they go to psychiatric hospital, which is segregated from
Well, the answer is both. The answer is both, and I'll tell you why in a minute. Actually, if we could just hold on to that question, I'll explain that. What we do have now, though, is if we just concentrate on adults, because that's what I want to concentrate on today, not children and the elderly. We have our general adult mental health services. That's what I work in, and in that we have some specialised services like forensic services, like services for treatment of people, say, eating disorders. We've got associated learning disability services as well. But we also have services in primary care. GPs actually provide the bulk of treatment for the people with common mental health problems, that's depression and anxiety. Our secondary services also provide for that, but mainly provide services for people with more long-term severe problems. You go to the next slide. We've also got to remember, and this is partly in answer to your question, not only are services provided by okay. You found yourself a seat. There's another one here as well, if somebody wants to say. Good.
Yes.
Well done. We're all sitting comfortably. Just to answer, this goes to your question. When I'm talking about mental health services, there are, of course, services provided by health services for people with mental health problems. They're also provided by social services, who may provide a day hospital, for example, but also social workers who work with us. I have social workers in the team I work in. But also, there's a range of other providers from the independent sector. Now, by the independent sector, I could mean the private sector, paid for services, but a lot of services are also run by, if you like, the charitable sector. So they're not-for-profit organisations that provide services. And they've been quite an important aspect of provision of mental health services in any local area. Private services are there, but actually they've not grown as much as one might have anticipated. And we'll ask some questions about that later. They're not as big a provider as we have for government mental health services provided through the National Health Service or social services or the charitable sector. Next one. I also want to remind you that we created a welfare state after the Second World War. 1947 became the mental state. It was this guy Beveridge who wrote a report on it. And what they were talking about and he talked about, was tackling the big five giants. And that was want, ignorance, disease, squalor, and idleness. Which meant want was poverty, ignorance was education, disease was providing a national health service, squalor was improving housing, and idleness was improving employment rates. Those were key things after, in the middle of the 20th century. We created a national health service which it's free at the time of delivery, paid for through taxes and national insurance. So if I want to pop to hospital, I pop to hospital and I don't pay any cash and I don't need to worry about insurance. If any of us wanted to see our general practitioner, we'd all be registered with a GP. We'd go along and see him or her, and that's how it's all worked. And I think the entire reason that psychiatry and mental health service has been so good in the UK, partly because we created the National Health Service, and that's what most of it is provided through. But it couldn't have been done without improving housing for people, without improving employment, without improving people's poverty or incomes, and people's education. All those are sort of supporting that. And remember, by having a GP meant that you could actually receive your pills, if you like, for your mental health problem easily. You didn't have to go without that. It also meant we could provide people better housing after the asylums. Well, next one. Asylums grew in number in the 19th century. It was a law that we created those asylums. It was an act of Parliament. But of course, what happened, as you can see, there was an enormous increase in the number of people in those asylums. These were big, and they were in several parts of the country. They contained maybe 1,500 people, 1,500 people. And they got bigger and bigger until 1955. And not only was I born in 1955, they also started to decline in 1955. There's no relation between my birth and that. Next slide. And you can see, there we go. They were pulled down, and the number of people in them decreased. But it was a slow decrease of people in these asylums. The last asylums were not shut in England until the end of the 1990s, and people had to be rehoused that were left in them. And that was an important process. So next slide. I just want to remind you, though, that this whole process between creating the NHS and the end of the 20th century didn't go smoothly. This was a government paper written in 1975. That government paper actually visualised what they thought mental health services should look like. And essentially, it said it should be specialist, but also associated with local authority and social services, residential, housing, daycare, work support services, and we should focus on local areas. So you provide for each local area a good, comprehensive mental health services. Now you also needed improved staffing. Staff quality of staff needed to be improved. But they said in that paper, and I think I don't usually believe in predictions for the future because they're hard to make, but they said even in favourable economic circumstances, it would obviously take a long-term programme to achieve in all parts of the country the kind of change we're advocating. Even within a 25-year planning horizon, discharge from a hospital into a community which lacks hospital facilities, i.e. inpatient facilities, might be a change for the worse. And they were perfectly right, because that was in 1975, and we didn't get our first plan, comprehensive plan, for adult mental health services until the year 2000. So they were amazingly right. And we did have problems in between. The transition from people being in asylums and our services running and centralised on asylums into providing them in the community did not go smoothly. It went well, but not smoothly. Next slide. What we saw actually in general was, the rundown of those old asylums went pretty well. Many of the people who were left in them by the 1970s actually did manage to get adequately catered for. They didn't end up homeless and on the streets like they did in the USA. That's still a problem for the USA. We didn't come across that. And actually, when we were putting people into ordinary accommodation, sometimes supported accommodation, sometimes not, most of them found that their social networks improved, they made more friends. They were generally happier in those situations. You always had a small hub of people who were going to be difficult to place, and I think that remains the same today. And people with multiple problems, challenging behaviours, forensic difficulties, alcohol, drugs, you name it, had a problem. But most of it was successful. Do you want to ask me?
Yeah, I have a question. Just to understand what is an asylum, basically. When I compare it to the Israeli system, we have two kinds of beds. We have the forensic, people are coming in and out like for 30 days on average, and we have the chronic beds. Would be
Long term.
exactly.
Long term.
So asylum would be for the chronic beds,
Long
basically.
term.
Yes.
Okay.
For the long term.
For the long term.
Yes.
And Jane?
Yeah.
Okay.
Yeah, it's a long term.
But as time went on, we also based some of our acute, our short-term hospitalisations there. But for many people that you saw in that slide with the graph, they were long-term hospitals. They'd be in for several years.
Okay. And the topic was like 1,500 beds.
1,500. No, 1,500 in one hospital.
In one hospital.
In one hospital.
One, yes.
In one hospital.
It
So how
was
much
huge
is
places.
I can't remember, but if we went back to that slide, we'd find out. We could do that.
I
at the
don't
end.
know to backwards.
We're talking about thousands of people.
Page
How
up,
many?
page up.
How many? Thousands?
Thousands of people.
Yes. Here.
This is the growth of the
No,
asylum.
another one. Kadima.
Kadima?
The growth
There.
of one asylum.
There.
Basic reduction of psychiatric
Yes,
beds.
but how many are there here in the...
Well, look, in
I can't see
1955, there were 155,000 beds in our asylums.
Do you have
35,000 in non-UK? Is it the number?
No, that's that.
No,
Well,
the
in
there's
1995, yeah, we had 35,000. Yeah,
35,
yeah,
20 years ago.
yeah.
Is it now the same amount?
No, it's less than that,
Yes.
and I can't remember the figure.
Yes.
So
But
there are
they-
still asylum beds.
No.
No,
No.
there are not. But what we do have is some forensic hospitals.
Yeah.
In
Max security it's called, right?
Yeah, we've got.
I've been
Okay, that's different kind of
Yeah.
I've been in Scotland in the two there.
That's it. Yeah.
Same.
In England, there are 3 high secure hospitals. They're for people, and they can be in there for their lives.
Very violent and
Yeah.
very
That's fine.
violent and difficult.
It's like Sharm and
Not chronic
Asher
beds
with.
in England.
No.
No chronic beds.
No, but of course, what?
But for the severe people like violence people, there are places. But it's very... Yes.
No chronic beds.
Not in the same way as these.
Not in this way, no. Yes.
I think truthfully there probably are, but they're shifted into a different sector, into the forensic sector, and people in
It's part of the forensic center.
But remember, this is catering for 50 to 60 million people.
Yeah.
So sort of roughly the. Go back again. A second.
Again or forward?
Oh, forward again. Sorry, forward. Yes. Back to where we started. Hang on. Go back again. One more. Yeah. One more. Keep going. Oh, hang on. You're going forwards. Oh, you're going forwards. Go back. To where we go. No, next one. One more. There we go. So, what I was going on to say, that most people with severe mental health problems, that's schizophrenia and another diagnosis, actually do live in independent accommodation. So 4 out of 5, I think, was the last figures I knew, with severe mental illness live in their own.
It's a condoms. It's in the community. Regular condoms, and in London and every place in the UK, you have houses like that.
Well, what I'm saying is 4 out of 5 people live in their own house,
In the home.
in their own, like I do. We all do. The rest of them are living in that sort of supported accommodation, and some nursing home accommodation, hostels and so on. And some will be living. There's a very small number now live in long-term hospitals, and that's mainly the forensic. So they are in that.
How many out of the 4 people do live in the house?
Now that's the other thing. Most of that group live in social housing,
Yes.
which means
That's what I meant.
No, זה
Yeah.
דיור ציבורי.
דיור ציבורי.
דיור ציבורי.
דיור,
בישראל
כן.
אין את זה פשוט.
רוב האנשים בדיור ציבורי.
יש לנו
translated
סיוע
in Hebrew, it's public housing.
דירה עיקרית.
Almost does not exist at all
here.
here.
Yeah. That was one of the things that happened. You remember I showed you the Beveridge report, and after the war, that's what happened. We built council houses in every area, and that was very important for people. We gave people affordable rents and so on. And until recently, houses for life as well. There's been a big change in that, but that was how it happened. And I just call it social housing, because quite often now, they're not owned and run by the local authorities, they're run by housing associations. So they're the social
כמו
landlords.
משרד השיכון.
דיור מסובסד.
זה דירות שלהם, כמו משרד השיכון. דיור ציבורי.
Like they get house services?
Do they get house services from rehabilitation? Like
Not
no?
necessarily.
Nothing?
No, it's not quite like that. Many of them will, because many people with schizophrenia will be in contact with services, so they get some support from our services. Some of those people who get support will also get what's called housing support.
Yes.
They'll have a housing worker that works with them.
Yeah.
That's not just exclusive to people with mental health problems, but they will give them what's called tenancy support. So they'll give them support to keep their tenancy, not, if you like, emotional support or social support and so on. But a lot of people do get some sort of support. Yeah. I mean, that's our biggest area that we have to work with in my team, keeping people well in their own homes. Okay. And there we go. I thought I had some of the figures. That's the most recent figures for people. There's about 50 beds now per 100,000 of the population for adults, and acute beds about 32 per 100,000. It's probably just a little less. Those
It's
are
like in Israel. Israel.
Yeah.
It's the same.
כן, זה.
3.2, 3.5, נכון דניאל?
0.41.
מה?
0.43.
ארבע
אתה לא איך
שעות.
אתה סופר את זה, אבל דרך אגב, כמה סופרים את זה יחד עם זכויות?
מיטות
ארבע שש. Almost 5 5%.
Das ist also chronisch.
5 beds.
הוא לא סופר את זה מכון. וזה צודק כרונית.
יחס משתנה לגמרי, שאתה מערב את הקטינים ומבוגרים.
זה אין פה.
כן.
So, we also, though, at the same time these were reducing in size, we also created community mental health teams. And that's been the important bit. And they really, the first one opened in 1978 in the UK. I was lucky enough to work in the second one, and in fact I did my PhD thesis based on an evaluation. So, that's my history. But in the 1980s, these teams started to increase, and by 2006 we had 826 teams across England, which is one team per 39,000 population. We had a lot of them. And those were figures that I got, official figures that we took out for the purposes of analysis. Okay, so they became very central to the way we provided health services. These are multidisciplinary teams, so they contain medics, nurses, occupational therapists, psychologists, social workers, and other workers, depending on the nature of the team. But they were multi-professional.
And those teams are run by the PCTs?
Well, we don't have PCTs anymore. That's the other problem.
Okay.
But these are
government, Daniel.
These are good. We've divided roughly our services into provider services and commissioning services. Right? The provider services are the organisation I work in. They're called trusts, mental health trusts.
Is that hospital-based or primary care based?
It'll be, well, primary care has got a completely separate organisation, right? So they're essentially our trusts are hospital-based.
So those things are hospital-based?
Yeah, they'll provide hospitals, but they also have buildings in the community that they also run. And most of these will not be based in a hospital, will be based in an independent building. But that was the sort of number we went to, and they were important. Okay, next slide. And that just describes them. Put the next slide on. And generally, they provide a good quality of care. The trouble is, I don't think we've evaluated them quite as strongly as we could have done, but it's difficult to evaluate. They're not easy to evaluate because you need a comparator. But they're much better than not having them. Next slide. Let me just remind you though, we did hit problems. This was not a simple, easy ride, because by the early 90s, people started to criticise our provision of community mental health care. This guy here, he's just an example. He was a patient called Clunis, who unfortunately murdered somebody, stabbed somebody on a tube station. And that caused a scandal, because it was felt that the public was suddenly thought to be at risk from all these mad people who were running around London. I mean, silly idea, but it's not true. But nonetheless, this got active. And by the mid-90s, you had that was from one of the tabloid papers. I'll sweep psychos off the street. That was supposed to be, but not. A quote from Mr. Dobson, who was the Secretary of State for Health at the time. What actually Dobson was worried about was that somehow community care for people with mental health problems was failing. I don't think he was right, but I'm glad he said it, because that pushed the government to actually improve things again. And we take the next slide. What they did was create this, which was called the National Service Framework for Mental Health, which was the first comprehensive plan for adult mental health services. And I think it's really important, this. And it was 25 years after 1975, which was, you remember that quote I told you earlier. And the idea was it set standards in 5 areas, and this plan was supposed to be delivered over a 10-year period. So by 2010 it was supposed to have been delivered. Take the next slide. 5 areas were important in this because firstly, if you look at standards 4 and 5, they cover services for people with severe mental illness, so people with schizophrenia and other long-term problems. And the plan was to set up new community teams. These were not just the general community teams, but specific ones. Home treatment teams, which would treat people acutely in their own homes. Assertive outreach teams for those people with long-term problems who were difficult to engage with services. And the third one were those people who were new onsets of psychotic illness. It was the first onset team.
So that's what we refer as ACT, aggressive community treatment.
Yeah.
Yes, that's
Is it-
right. That's the other word for it. It's the American
Yeah,
idea
it's-
that we imported. But the other good thing was that the other important thing, there was money for this.
Very aggressive.
Because quite often what politicians do, as you know, they tell you how good something should be, but don't give you any cash to provide it. But also, importantly, it said we've got to think about mental health promotion and discrimination and exclusion. So we were getting mentioned in this field early on. There was also, they wanted to improve conditions for primary care, that's general practice. They also, and this was surprising, that this was shoved in but important, that carers should be supported more. So I think carers have felt left out of services. And the final one was about action to reduce suicide. So it's a little bit of a nudge there to public health services. So this was really important. So let's go on. And yes, after that, we got an improvement in the amount of money that was coming into mental health services. Actually, when we looked at it, it was quite erratic, this, but over time, over the next 10 years, it did improve. You take the next slide. I had to work with an economist, you know economist. And he was very good, but he made me do all the work, and then he just added it all up at the end. And these were the figures we came up with. They're not perhaps in the best order, but when the National Service Framework was supposed to end in 2010, we thought they needed approximately £7.5 billion to provide the services they promised in the first place.
How is it in the terms of the national
Yes.
expenditure?
That's nationally, yes.
Yeah.
No, for health.
From
No,
all the
no.
budget of the UK,
Yes.
how
No,
much
no.
is in percentages? 5%, 10%? You know?
Oh, I don't know. I can't remember how many billions we spent, but it's probably about 10% of
10%
it. Yeah.
of the whole
Yeah.
budget.
Yeah.
Huh? No.
Maybe
No,
the whole,
that's-
the whole,
לא, כמה
בריאות.
health מתוך ה...
the whole health system
The whole health
maybe
system.
have
Or
10%,
only-
right?
Only the mental health.
No, the whole health system.
The whole health.
Yeah.
בישראל 8, זה לא
כן, זה
רחוק.
10%.
8.
כן, אבל זה עדיין פרטי.
Okay.
אין
Fine.
ציבורי. שתי בעניינים.
And the mentally health system from this, the whole health?
I don't know the answer to that, I'm afraid. Actually, this is just for adults.
It was today in the morning in the Knesset. It was in the
Questions?
Was the
yes,
question.
the questions. Yes, it was.
Anyhow, they did quite well. They were thinking they were going to spend about $6 billion on it. So what I'm saying is actually the government didn't do badly.
I want you to introduce Tal. She's the head of the health, the
Mental health
mental
service.
health services. That's right.
Hello, I'm Jed Boardman. So government didn't do too badly, when in fact they'd done very badly before, actually, because I don't think they'd ever put enough serious money into mental Next slide. Oh, look, just to remind you actually, in the middle of it all, Louis Appleby, who was he was the senior doctor involved in the NSF and the government. He said the next few years what we need to do is prioritise social inclusion and also psychological therapies, which to some degree they have done, but not as successful as they thought. Next slide. Now remember, at all this time, you need to support this somehow by other government policies. And here are some of them, actually. That we actually created a Human Rights Act, which I think our current government would like to get rid of. But what is important, we created in 1995 the Disability Discrimination Act, which is now part of the Equalities Act, along with sex and gender discrimination and so on. But that actually was for people with disabilities as a whole. So it does include people with mental health problems. They're not separate from people with physical disabilities. That's been very important, particularly things like access to services and employment. We also set up at the end of the 90s a government piece of work on social exclusion. It was called the Social Exclusion Unit. Initially it was in a thing called the Cabinet Office, which is the Prime Minister's office. It was then moved to the Deputy Prime Minister's office. But what that did produce was a lot of stuff on social exclusion. But remember that definition I gave you at the beginning, that came from them. And it also produced a very good document on social exclusion and mental health. It was the reason I did this work in a way, because I just saw an opportunity to do this within the college to let us fit in to what I saw as a big opportunity to sort of have a government dialogue about social exclusion and mental health. We also had big changes to health and social care. We have a Health and Social Care Act, several of them, but they've been put together because I think traditionally we've always had this idea that health and social care do actually go together. And we also have the new Mental Health Act, which I won't go into. So there's our Social Exclusion Unit document, and if you look at it, that's the early, that's not from that document, it's a separate one, but again it's looking at work, education, what happens to children when they're deprived, older people, housing, poor neighbourhoods, etc. All of which are sort of integral to what you should be looking at as a sort of general national policy. Okay, next one. There were also a number of other policy initiatives. We had in the department that covers welfare benefits and employment is called the DWP, the Department for Work and Pensions. And that had a whole stream of work on employment and health, of which mental health was highly recognised. This was the big Carol Black's review. She was a doctor. Their own review about working way to better health, and this one, which was done by Rachel Perkins, who's a big enthusiast on work. She's a service user herself, and she wrote a lot there in that document about supporting people with mental health problems into work and helping them stay at work. And that was a DWP document. 2, work recovery and inclusion. We also had the Boardman review, which was about the health and well-being of the NHS working population, people who worked in the NHS, because you can't actually somehow transmit